Welcome to another episode of Talking with Docs. I'm Dr. Brad Wiening.
And I'm Dr. Paul Zalzal.
Today, our episode is essentially, so I have a torn meniscus. What now?
Yeah, this is a very common thing that we see in the office, is people coming in with evidence of a torn meniscus. So we should probably start with, what is a meniscus?
So I tell my patients that the meniscus is a tissue that lives between your thigh bone and your shin bone and acts as a shock absorber. There's one on the inside called your medial meniscus and one on the outside called your lateral meniscus. In this model here, this is your femur, this is your tibia, and the meniscus looks like that. When I describe how it functions, I tell them it is a shim. It's thick on the outside and tapers in to be very, very thin on the inside, almost paper thin.
I usually say it's a donut shape.
I like donuts, and as Canadians, we like donuts.
Usually, because my office is around lunchtime. But yeah, basically it's a shock absorber, as Brad said. So you have the femoral condyle, which is the end of the femur, is quite round, and the tibia is quite flat. And to have a round object on a flat surface, that would create a lot of stress between the two. So this donut or shim distributes that stress so that it's not high pressure points in the joint.
And so then usually people come to me, Paul, and they say, well, how did I even get a torn meniscus?
Right. Oh, well, meniscus, you can get a tear in your meniscus acutely from trauma. Usually it's a pivoting maneuver during a sport. However, you can also get a tear in your meniscus from a degenerative process.
Just like being middle-aged.
I guess, yeah, I have to put it that way.
Yeah, so often it's someone who's 40, 45 years old, and people come to me and say, I just woke up and now my knee is sore, and sometimes it can be something as simple as that. Yeah.
My knee hurts right now after that.
After sitting in this chair for so long. How do you diagnose a meniscal tear, Paul?
That's a good question. Always, when you go see your physician, you'll find that they start with a history. They ask you a bunch of questions about your symptoms. You know, where do you have the pain? When did it start? How did it happen? And then that's followed with a physical exam, where we examine your knee and look if you're tender over one of the meniscal insertions. So on the medial side of the knee or the lateral side of the knee, if you're tender there. And then there's some specific tests we can do which load the meniscus and can also give us a clue that this might be a meniscal tear.
Yeah, I agree. Usually I tell people, if you have things like sharp stabbing pain, rather than more like a knife compared to like a toothache, that's more typical of a torn meniscus. Or the other thing that I get from a history is if there are specific activities that aggravate them, like kneeling and squatting or planting and twisting type activities that makes it worse, sometimes that can increase your suspicion for a torn meniscus. And then the other thing, I guess, beyond history and physical examination is investigations. Some people say to me, well, can you see a torn meniscus on x-ray? The answer is no. X-rays are good for assessing the bones and the spaces between the bones, so the amount of arthritis that you may have, but an X-ray cannot show a torn meniscus.
However, it is still, even though it doesn't show a torn meniscus, the first investigation that we do if you're coming in complaining of knee pain. You should always start, I think, anyways, with an X-ray.
Please, a weight-bearing X-ray, unless you can't weight bear on it. Please,
yeah, definitely start with that before you go into anything more fancy, such as...
So fancy sometimes is ultrasound, which I certainly am not a big proponent of for knee pain.
No.
Unfortunately, it is a more readily available test, and it's a little bit cheaper than an MRI, so often people will get them and they say, hey, my ultrasound shows a torn meniscus. I think that is not a particularly reliable test for meniscal tear, and I would not order that test.
I agree. I don't get a lot of information from an ultrasound of the knee if I'm looking for a meniscal tear. I think ultrasound of the knee is important if you're worried about a tumor, a mass, or a soft tissue condition such as infection or abscess or something like that around the knee. Fine. Fluid. But looking in the knee, the ultrasound's not great for that.
And that leads us to probably the gold standard diagnostic test, which would be an MRI.
Yeah, I think an MRI really is, so a magnetic resonant image is really the best way to diagnose a meniscal tear using imaging.
Yeah, and it's just a big magnet that allows us to get really accurate pictures of the soft tissue depending on the amount of water in them.
Exactly. So we've done a history, physical examination, and some investigations, and you've been diagnosed now with a meniscal tear.
So before we move on, Paul, does everyone have to have an MRI to diagnose a meniscal tear?
No, there are. You can be pretty confident in some situations from your history and physical examination. There's one classic situation I'm thinking of. It's a locked knee. So if you're in a situation where your knee is stuck, you can't extend it out fully straight.
Or bend it past a certain point, I guess.
Or bend it. That can be caused by a tear in the meniscus that has caused a piece of the meniscus to flip into the joint farther, and it's stopping your knee from extending. That's called a locked knee. It can also be caused by a loose body or a torn ACL or other lesions, but if you have a locked knee, probably the most common cause would be a bucket handle type tear of the meniscus. So I don't think you need an MRI in that setting.
Yeah, good point. That leads us to treatment.
Yeah.
Where do you start?
Well, it's funny, we're surgeons, so we love doing surgery, but we always start treatment with non-operative treatment first. We try and reserve surgery for the last, as a last effort. Of course, in a locked knee, generally that's going to go straight to surgery, but the vast majority of meniscal tears we try and treat non-operatively. So activity modification, anti-inflammatory, physiotherapy, and time, really, to see if the symptoms settle down.
Yeah, and a lot of times that's even done before you get the referral. Sometimes if you're seen by a family doctor or another type of physician rather than a surgeon, some of that stuff may be taken care of even before you got to the surgeon's office.
Right. So you've done this now. Let's say I've got a meniscal tear. I've tried a bunch of non-operative treatments and my knee's still bugging me.
So you mean that's not going to cure my torn meniscus?
Yeah, it's not going to cure it.
Right. So I think that's important for people to recognize that when we recommend all these things, we're not necessarily doing it because we think it's going to heal the tear. Because unless you're 10 or 12 years old, the probability of a meniscal tear healing without some type of intervention would be very, very low. So the goal is to reduce your symptoms. And if your symptoms become tolerable, then you might be able to avoid surgery.
Yeah. The meniscus doesn't like to heal itself because it does not have a great blood supply throughout the majority of the tissue.
I tell my patients that that's a design flaw, but you got to be a little bit careful saying that.
Yeah. There's a lightning strike coming down. I'm moving.
That's right.
There is a good blood supply in the periphery of the meniscus. So if it's torn way out to the outside, which is very rare, the meniscus can heal out in the periphery. But generally, meniscal tears don't heal on their own. But the symptoms from a meniscal tear can go away.
Yes, for sure. And commonly you see that people say, I used to be really, really sore, couldn't stand on it, couldn't bend on it, and now it feels good. Usually I tell people, hey, even if you have an MRI that says you have a tear, we're not obligated to do something because you have a tear. We're obligated to do something because your symptoms are not manageable.
Agreed.
So what about surgery?
So the surgical procedure for a meniscal tear and symptoms being caused by a meniscal tear would be arthroscopy, which is a type of surgery. It's very minimally invasive where we put a camera and some instruments inside your knee through 2 or 3 small portals.
Yeah, so usually when we do it up in Canada here, people would go to sleep. Sometimes it could be done under a spinal or regional anesthetic, but lasts about 20 minutes or so, depending on the amount of pathology inside of your knee. And like Paul said, you look around and then do you fix the meniscus, Paul?
Well, if the meniscus is torn in the very periphery, which is rare, an attempt at fixing it can be made, but the vast majority of the time what occurs is something called a debridement, where we just shave off the part of the meniscus that's torn and not doing its job anyways because it's torn. We shave that off so it doesn't get tugged and pulled and cause those mechanical symptoms, we call them, where the catching, locking, giving way sensation.
Yeah, I tell people I liken it to clipping your nail. So there's a little piece of your nail that's kind of getting stuck, and you just trim it away, trying to leave as much of your normal meniscus as possible. Some people say to me, well, is that bad? Don't I need that piece of meniscus?
Yeah, I get that question a lot too. However, that piece of meniscus is not doing anything anymore because it's torn away from its normal position. So no, you don't need that piece of meniscus that's torn. Now, the fact that you tore your meniscus, is that going to put you at risk down the road for arthritis? That's a good question.
I think that it does. It's indicative of abnormal loading of your knee, particularly in the degenerative setting. So the fact that you don't have as much of that shock absorber as before, I think it does increase your chances of arthritis. I think by having arthroscopy to remove the torn piece, I do not think that increases your risk any more than the fact that you have the tear.
Or decreases your risk. It's not going to change your long-term outcome. It's really for symptoms.
And traditionally, people used to take out, like surgeons used to take out the entire meniscus, which we learned pretty quickly was a very bad idea and led to arthritis much faster.
So we did learn from history that if the whole meniscus or a big, huge portion of it is removed, then yes, you will likely get arthritis in that knee down the road.
What do you tell people to expect after surgery, Paul, as far as activity and healing time and that kind of stuff?
Well, I tell people you're going to walk out of the hospital, and it takes a couple of weeks for the sort of pain and swelling to settle down, and then, you know, return to sports, maybe 6 weeks. These are general guidelines, and everybody's different. Certainly I've seen people get back much quicker, and I've seen people take a little bit longer to recover from meniscal surgery.
Yep, I'd agree with that. I tell them I give them some pain medication to control the acute symptoms. They can use over-the-counter medication after that. They may or may not require some physiotherapy, typically not a brace. And then, with the goal being once they have minimal amounts of pain, near full range of motion and strength, then I let them get back to sports.
On the rare occasions where you might have had a meniscal repair, that post-operative period is very different. You're going to go through a period of time where you may not be allowed to weight bear on your leg, you may not be able to bend it to beyond a certain degree, and that process takes a lot longer to recover from. But that is not as common as a meniscal debridement.
Before we leave this topic, Paul, I just want to ask, what if your MRI and your x-ray show that you have a torn meniscus and you have moderate to advanced arthritis? This is a common problem.
That's a very good question.
People say, hey, I got a tear, you got to scope my knee.
Yeah, so you have arthritis in your knee and you have a torn meniscus. I tell people that the tear in that setting, the torn meniscus is part of arthritis. Arthritis is a degenerative condition where you have wear and tear of the cartilage in your knee. You have cartilage on the joint surface, and the menisci are made of cartilage as well. So that tear is more of the part of the process of arthritis, and a scope will not likely help your overall symptoms significantly, and that's been shown in the literature by some friends of ours who've done some research in this area.
Yeah, so I'll tell my patients that have significant arthritis and a tear, if they do develop kind of new locking, catching, giving way, or sharp stabbing pain that's different from their arthritic pain, those are the people where they may benefit from arthroscopy. I tell them our goal is to reduce that sharp pain, but that the dull aching pain is going to persist because putting a camera inside your knee does not affect the arthritis at all.
Yeah, I use an analogy. I don't know if it's very good, but if you have a knee that's so arthritic that you're considering replacement and you have a meniscal tear and you're wondering, oh, well, if I scope it and deal with the meniscal tear, will my knee feel better? I say it's like you have an old car with a flat tire and the car doesn't run. If you pump up the tire, is that going to make the car any better? No, the car is still not going to run. You should probably consider getting a new car. Now that's a little bit of a simplification, I think.
Yeah,
But do you get what I'm saying?
I get the point. I get the point. So I'd agree with you because every knee that you replace has a torn meniscus.
Yeah.
Invariably. So I think that's a good point. So proceed with caution. It's not an absolute. Some people with arthritis and meniscal tears will benefit from arthroscopy, but that would not be the standard treatment.
I agree.
Anything else?
I think that pretty well sums up. And the other thing is the procedure doesn't take very long. I think it probably takes about as long as this video took to treat a meniscal tear.
I feel like this was harder.
Yeah.
So if you have any further questions on any topic, certainly we'd be happy to answer them. Send your requests to talkingwithdocs@gmail.com.
And remember, you are in charge of your own health.
See you next time.